So we're going to get started. I feel like we could have done this in our living room instead of having, because we know most of the people here. My name is Kira Copperman. I'm a co-chair of today's luncheon. Just want to welcome you to the Mount Sinai Women's Health Day. Definitely a great day for everybody to learn about women's health and for some people to play hooky. You know who you are. Many of us. So the money raised today is actually going towards women's health initiatives at Mount Sinai. And just out of curiosity, how many of you have seen or do see a physician at Mount Sinai? Yeah, pretty much everybody. So I think we could probably all agree that Mount Sinai is best in class in terms of everything from clinical care to the administration to the whole experience. And so the women's health initiatives really do, they are at the forefront of helping people with their health issues. So I'm going to introduce somebody I know very well. It's very unusual to introduce your own husband, but his name is Dr. Alan Copperman. I know. To me, he's honey, but I'm going to read his title because I honestly don't know it by heart. He's the director of the Division of Reproductive Endocrinology and Infertility. He's clinical professor and vice chair of the Department of Obstetrics, Gynecology, and Reproductive Science at Icahn School of Medicine at Mount Sinai. He is also the founding partner of Reproductive Medicine Associates of New York and serves as its co-director. But most importantly, he happens to be a terrific father and husband, but also an amazing doctor. And I can tell you firsthand, he spends every day of his life trying to improve his ability and his colleagues' ability to take care of patients. And so I'm really proud to introduce my husband.
I like it when you call me Dr. Copperman. Yeah, that'll be the last time. Really a privilege and a pleasure to be talking to friends, to colleagues, to this esteemed group in this location, in this venue. I mean, the Plaza is just one of these fabulous places in what I consider as great a city as there is in this country. And I'm honored to be talking to you a little bit today. I'd like to be informal. It's a small group. I'd like to try to tell you a story about women's reproductive health and really taking you through the journey from before birth until after menopause begins, and talk a little bit about state-of-the-art, pop culture, what makes sense, what doesn't, what's truth and evidence-based, and what's anecdotal experience, and what's kind of the world of make-believe, and help demystify some myths, debunk some untruths, and maybe be forward-thinking and figure out where we're going in the field of reproductive medicine. A woman's born with all the eggs she's ever going to have in her entire lifetime, and in her 20s, 90% of the eggs are normal. By the time the average woman's in her 40s, 90% of the eggs are abnormal. By the time a woman goes through menopause, she still has somewhere between 1,500 and 2,000 eggs. So what happens to all of those eggs? If she's born with, in fact, when her mom was 20 weeks pregnant with her, a woman could have 4 million eggs. At birth, 1 million eggs. At puberty, 400,000 eggs. And at menopause, 1,500 eggs. So where do all these eggs go? Most of them are actually programmed to just stop growing over time. The word is apoptosis, programmed cell death. The eggs just are told to not ovulate, but every month one is chosen and does ovulate and hopefully becomes a healthy baby when a woman is trying to conceive, and of course doesn't fertilize or implant when a woman's not trying to conceive. So when you think about the 500 eggs, I almost think of, Billy Crystal had that show, 700 Sundays. And 500 eggs is really the story that we should be telling right now, from the time a woman goes through puberty and has her first period after the onset of puberty. So that's the real question that's coming up in the pop literature a lot: is puberty earlier than ever before? And the answer is convincingly yes. Puberty just 50, 60 years ago was commonly started at 10, 11 years of age, and it's now not uncommon to start seeing puberty at 7 or 8 years of age, especially. We know that puberty is coming earlier. The question is why, and there are three prevailing hypotheses right now. One is that nutrition is just better. We're feeding our kids better than we did 50 or 60 years ago. The average 8 and 9-year-old maybe has a maturation of their axis. The hypothalamus, the pituitary, and the ovaries are just better nourished, better able to go through their process, and so it's certainly possible that women are just more prepared at an earlier age to go through the reproductive process because the body's pretty smart and wants somebody who's capable of reproducing, who's healthy, to ovulate and conceive, and a woman who's not healthy to not. But that's not entirely the whole story. We know that obesity is a major problem in the country, and we know that body mass index is a major trigger for when the body's axis starts to mature and when a woman starts to ovulate. So the obesity epidemic is clearly contributing to the earlier puberty. And then there's a whole new field of endocrine disruptors. Everybody's talking about environmental toxins, and we're all a little bit afraid. It turns out in the United States alone, over 700 new chemicals are approved and released and used in our hair products and our lotions and our plastics that we store foods and containers. So there is a lot of theories that these endocrine disruptors, these new chemicals, can bind to the estrogen receptor. So whether it's a combination of better health, whether it's a byproduct of the obesity epidemic in the country, or whether it's some of the new chemicals that we don't really understand exactly what the effects are, it's clear that women are starting to develop earlier, and this does have psychosocial consequences. 8-year-olds, 9-year-olds with breast development, 9-year-olds that are and 10-year-olds having their periods is very different than our society has seen in the past, and I think one that the psychologists, the sociologists are paying a lot of attention to, because I don't think we're going to be turning back the clock, so I think that increasing the preparedness at an earlier age is really part of what one of our fundamental objectives has to be for women's health. Well, as a woman ends up going through puberty, then the next question is, of course, contraception, and contraception has become more and more politicized, but more and more available, fortunately, in the country. And so the birth control pill is, I think, more protective against disease than anybody has ever realized. You know, years ago, people thought the birth control was going to cause cancers later on, was going to cause trauma, was going to cause problems. It turns out the birth control, there's nothing better a woman can do than take the birth control pill to ultimately prevent ovarian cancer, to promote her life expectancy in the future. Birth control, it's not just by stopping the ovaries from ovulating and having repair of the ovulatory damage each month. It seems to be a whole bunch of hormonal things that happen inside the ovary, but the birth control pill prevents the ovary from causing some of those mutations later on in life that can seem to be predisposed to ovarian cancer. We could talk a little bit, the other way that you can prevent ovarian cancer, and this is fairly new information, is taking out the fallopian tubes, because most ovarian cancer isn't really caused in the ovary, it's all starting in the fallopian tubes, but we'll get to that later on. So the question that comes up all the time these days, and we're talking about pop culture in this world of the Kardashians in which we live, is what about egg freezing, and what is the truth, what is the reality? Is this something that every woman, some women, no woman should be doing? What is the likelihood that if we freeze an egg, it'll someday become viable? And how many eggs do we need to freeze so that we can actually preserve reproductive potential? And we get a lot of our data from oncology. We've been freezing eggs in patients with cancer prior to chemotherapy, prior to radiation. We've been doing this for more than a decade. And the process itself is pretty straightforward. It's about a week of fertility medication. So just like with in vitro fertilization, you give FSH and you stimulate the ovaries make a whole bunch of eggs. We then retrieve them when we could preserve the eggs. But it's actually a little bit more complicated in cancer patients because we don't want their hormone levels to get high, because we know that estrogen, for example, somebody with breast cancer, can be a bad thing, can stimulate tumor growth. So we're using medications such as letrozole right now to prevent estrogen levels from getting high. So I would say that right now, any woman, any man as well, but any woman of reproductive age diagnosed with cancer should really consider a visit to a reproductive endocrinologist to freeze their eggs. It's one of those, there are certain good deeds I think we could string together. There's certain bits of information I think it's important to take home from a lecture and spread the knowledge. There's no reason for a 35-year-old woman who wants to someday have children, who is diagnosed with cancer, to actually go through chemotherapy or radiation or surgery without having somebody have a conversation that the hype is actually matched now by the science, and they can preserve their potential to someday have a child. And it's new and it's exciting, and we just keep getting better and better at preservation of fertility, and I think that women are living longer and longer after all types of cancers, meaning that we have to focus not just on curing them of disease, but in preventing the long-term side effects of chemotherapy. And that's really important when you talk about quality of life, when you talk about some of the other side effects from chemotherapy. It's not just survival, but all of this is really meaningful survival. And quality of life means many things to many people, and it's not just health to do certain things, but in many cases, and we're starting survivorship programs with Mount Sinai so that even if women haven't preserved their fertility, there are still ways to help many women and many couples have healthy children over time. So elective egg freezing is another whole topic. So these are women who want to preserve their options to have a baby, and they understand the graph, that if you're in your 20s and 90% of the eggs are normal, and if you're in your 40s, 90% of the eggs are abnormal, then how can we actually find a time before most of the eggs are abnormal to preserve the healthy eggs? So 10, 15 years ago, it was considered impossible to freeze eggs. The eggs are filled with water. You put them in whatever freezing techniques you use. They would form ice crystals because all that water crystallizes. It would break off the spindle. The eggs would be damaged and wouldn't be viable. In addition, when an egg is frozen and thawed, the shell gets really, really hard, and it becomes difficult for a sperm to get through. Well, we've bypassed the problem of this hardening of the outer layer of the zona pellucida by taking sperm and a procedure called intracytoplasmic sperm injection, or ICSI, and taking the sperm and putting it directly into the egg. And we've improved egg freezing techniques by, instead of the slow freezing technology where we actually take in a program freezer, take the eggs, dehydrate them, and take them down 1 degree a minute until we finally plunge them into liquid nitrogen. And now what we're doing is something called vitrification. And vitrification is a fantastic advancement. What it means is flash freezing the egg. So we still dehydrate them. We still use cellular antifreeze, just like you keep your car from freezing. And over the winter, the cellular antifreeze prevents the water from crystallizing, and then rapidly we plunge the eggs, or the embryos, it's the same technique, into liquid nitrogen. And it's incredible because you could rewarm them an hour later, a day later, a decade later, and they come out looking exactly like they went in. So the technology of egg freezing has actually grown to the point where we can't take an abnormal egg and turn it into a normal egg. And if a 45-year-old comes in, the odds are we're not going to be preserving her fertility. We'll probably just be preserving infertility at that point. But if we actually take a chromosomally normal egg and freeze it, we have a 90-some-odd% chance that that egg is going to effectively thaw. At that point, the story isn't over, though, because it's not just about getting a healthy egg. The key is when we thaw the egg, we still have to fertilize it, meaning that there has to be a normal sperm. We have to be able to grow that embryo, and we'll talk a little bit about embryo selection. We can actually figure out which embryos are normal or not these days, but then we transfer the embryo, and even then, a chromosomally normal, healthy embryo still has only a 60 to a 70% chance of implanting. So humans are ridiculously inefficient at reproduction. Some animals are fantastic. They can look at each other from across a pond and get pregnant with quintuplets, but not humans, because not all eggs are normal. They don't always fertilize. They don't always implant. They don't always stick. So if we can at least take away some of the aging process, then we will start with a healthier cohort. So how many eggs does a young woman need to preserve so that she has a good chance ultimately of conceiving once she's ready to conceive? Well, it depends upon how good the eggs are when we take them out. If it turns out we're taking out a 21-year-old egg, we could probably need 5 or 6, and we're going to do fine. If it's a 41-year-old egg, we may need 25 or 30 eggs, because by the time we find that 10% that are normal and they have to survive the freeze-thaw, fertilization, and implantation, it's simply a numbers game. But that's a lot of what we're doing these days, is using statistics and genomics and personalized medicine to drive the reproductive journey. This is very different than doctors spoke a decade or 20 years ago. This is real. It used to be my anecdotal experience, what my professors taught me, what the textbooks say. I mean, the number of times that I've picked up a textbook recently, and it's not because I don't want to learn, but because that's not where the knowledge is, because the knowledge is changing so fast. In fact, we find ourselves creating the knowledge base very frequently. But when we talk about an evidence-based journey, we're talking really about data-driven medicine these days. So for egg freezing, I would say that a 35-year-old that wants to have 1 baby, probably 10 eggs. A 35-year-old that wants to have 2 babies, probably 20 babies. There are some communities nearby that may be the norm. But depending upon the health of the eggs, we can actually predict how many eggs and therefore how many embryos, and they ultimately have a likelihood scenario of how many babies. And it's so interesting, but when a couple comes in these days asking about fertility, we're asking questions differently. I'm no longer saying, so do you want to get pregnant? I mean, I might have said it more elegantly than that. But the question is really, what does your family look like that you'd like to have? What is the family of your dreams? Is it 1 baby? Is it 2 babies? Or 3 babies? Because This vitrification technique, this new technology and our ability to freeze and thaw embryos has changed the game. We can actually put aside 2, 3, 4, 5 normal embryos and then ultimately help most couples achieve whatever it is that their family building dreams are. So for elective egg freezing, I think we've got the story pretty laid out. I think that the technology is pretty good. The one cool part of our field right now is genomic medicine. One of the studies that we're doing these days is we're looking at genetic markers to figure out which women are at risk of going through early diminished ovarian reserve, early reproductive senescence, early infertility, and which women are probably going to stay fertile, because most of our biology is actually predetermined. It's all predestined. So we do have some control. If we smoke, we have an earlier menopause. If we have poor nutrition, we can actually see diminished ovarian reserve earlier, but the real story that we hear these days is there are biological markers, there are genes that are turned on and turned off. In fact, a lot of our genetic makeup is determined even before we're born. So when our moms are pregnant with us, whether or not they smoke, it turns out may have some effect on imprinting, on whether our genes get expressed. And the other real interesting part is what our mom eats. Maternal obesity actually is changing the way the genes are imprinted of the fetuses. And this is a study that we're doing with Mount Sinai right now. We're looking at polycystic ovaries, and we just unblinded our first 50 patients that we had collected both mom's information and the cord blood on, and it is so clear that the genes expressed are different from when women are obese, when women are diabetic, when women have high cholesterol, than when women are in optimal health. So what we're learning is it is the DNA that we've been given from our parents and grandparents and ancestors, and it's also the gene expression, whether that DNA, so the DNA is that phone book, and the gene expression is when you read it out loud and it actually means something, and then those genes will make proteins, and those proteins make up who we are. So it is not only the DNA that we're giving, those 3 billion base pairs, and what are the A's, the T's, the G's, and the C's, but how they line up to make 20,000 genes, and how those genes get expressed, that we have some control over, the nurture, and that we have no control over, which is the nature. So our reproductive lifespan is probably somewhat predetermined, but also we have some control. For example, the young ballerina that doesn't eat as well and is exercising all the time, she's not going to ovulate because the body's pretty smart. The hypothalamus knows, and you can go back to caveman times, if there is a famine, if there is times of stress in the community, the body's pretty smart. They don't want to waste time menstruating, ovulating, getting pregnant. That would really be unhealthy for the survival of the individual. The key is to actually wait until better times, a little bit more body fat, for example, a little bit more food in the village, for the woman to resume that normal hypothalamic pituitary ovarian axis, the reproductive life cycle. And so you fast forward a couple of millennia from the caves to the Soul Cycle and Flywheel Studios of New York, and you do see that there is this preservation of the reproductive story is still being told today, where some women who are either obese and unhealthy, so in an unhealthy way and morbidly so, may not ovulate normally. Same thing with women who are extremely thin, may not ovulate. So when a couple walks in saying, all right, now I'd like to figure out whether I can conceive, because we're doing reproductive checkups these days, or now I'd like to get pregnant. And this isn't just couples. It's same-sex female parents, it's single moms by choice, it is same-sex male parents come in, and people are asking the questions these days, so what do I need to do to have a healthy baby? And that's where some of the myths and pop culture stories come into play, and that's where the factual information is really important. So ideal body mass index is very important, not smoking, eating well, doing some weight-bearing exercise. There are some things that we can control. And the new story these days is genetic testing. Women and couples before they get pregnant used to have just cystic fibrosis or sickle cell anemia that could be tested for. The new story is that there are about 6,000 single gene mutations, carrier testing it's called, diseases that we can carry one mutation, one little A for a T or G for a C that can cause a baby with Tay-Sachs if both we and our co-parent both carry the same mutation. So we're now able to test mom and dad, or egg source and sperm source, before even trying to get pregnant or before even creating an embryo in our laboratory. So it was 3 diseases. In fact, there are religious groups that have been doing this type of testing to help arrange marriages for about 30, some odd, maybe 40 years or so. There was a group that started in Brooklyn and is now now worldwide, and there are offices in Israel, including, so in an arranged marriage, you would want to make sure that the future mom and dad, the bride and groom, aren't going to have an unhealthy baby together. So they started doing the pre-first date testing to figure out who would be a candidate to the first date. Long before there was Match.com, or more relevantly, JDate in this situation, they would test mom and dad, and then it turned out that that wasn't cost effective at all, and so they were waiting for 5 or 6 dates was the next iteration. They figured that that was too late because couples had already fallen in love. So in the Jewish community, it's a 3-date rule for this, which I think means different things to different people. But it now is 3 dates, and then they give the go-ahead whether we're going to take the blood from mom and the date from the dad, and this is actually fairly recent. This is in the last year, it changed to a 3-date rule. And hopefully there are things that you'll learn today that will take home to the next Seder or cocktail party or whatever, and you will now be an expert on the idiosyncrasies of reproductive medicine that we deal with each day. And it is the combination, which I find so exciting, of the ethics, the pop culture, the science, and this vision of the future, because it's changing all the time. This is all hitting a moving target. So now we test future mom, future dad for genetics, and if it turns out that, and this is so interesting, Sinai just went to close to 300 diseases on the new expanded carrier panel. It's probably going to be 500 by next year. It'll probably be all of the diseases within the next couple of years. So if you take an Ashkenazi Jew on the Upper East Side of New York and you test her for 200 single gene mutations, it turns out 70% are going to be positive for one mutation, of at least one mutation for one disease. So we're having a whole problem right now in conveying all the knowledge to everybody, because you take a young, healthy woman and just walks into your office and now I want to have a healthy baby, and say, oh my God, you carry this this mutation for maple syrup urine disease, Nemeline myopathy, Fragile X, Gaucher's type 2, these things that nobody's even heard of, and people who are healthy are now thinking that they're sick. So there's an information shift, and part of what it's our responsibility in the field of reproductive medicine is to help educate the public that having a copy of a mutation doesn't mean that you're sick. Having a copy of the same mutation that your partner has means that you have a 1 in 4 chance of having an unhealthy baby, unless you either test the embryo, and frankly that's pretty easy to do these days, is to test an embryo for a disease that we know about, or do testing early on in pregnancy, and that could end up being a little bit more problematic for couples sometimes, because there are obviously social issues and emotional issues that come along with testing at 11 weeks or even at 18 weeks on an amniocentesis, and sometimes having to make some tough decisions. So the future of medicine is indeed preventive and not therapeutic, and that's what we're spending a lot of our time doing. If we could prevent patients from being in that uncomfortable situation or the really horrible situation, then we will have prevented a lot of suffering, and that's the paradigm in medicine these days. So that couple comes in, and the most important thing you can do when they come in asking why they're not getting pregnant is to ask some questions. It turns out with just a simple history, physical examination, ultrasound, we could probably figure out why 90% of couples aren't getting pregnant. And this is shocking to people, because everybody knows somebody with unexplained infertility. They can't figure it out. It's really not that complicated. We're kind of plumbers. It's the eggs, it's the sperm, it's the uterus, it's the tubes, it's the timing. I mean, I don't mean to make it sound unsophisticated what we do, but there really are the basics. And it amazes me that in 2015 there are still couples that have been trying for 2 years but have never had this male tested. Again, take-home point of always test the male. You never know what you're going to find. And it turns out that there are public health reasons to test a male. So if a couple can't get pregnant and it turns out that the guy has erectile dysfunction, well, that may be a young guy may very well be a marker for cardiovascular disease. He can go to a cardiologist. It turns out you may save his life just by asking the question, hey, how often are you having sex? Are there any issues? A guy that does a semen analysis and the sperm count is low, he could have low testosterone. He could have a high prolactin level and a pituitary tumor that nobody's ever diagnosed. Just by thinking through the problem, you can actually figure out whether there are any public health issues and not just check it off the list to say, well, do a semen analysis or not do a semen analysis. And there are indeed occupational, environmental exposures, radiation, things that a guy can go through. He could have had an undescended testicle, he could have had an infection, he could have had testicular trauma at a young age and have antibodies. So male factor is important, but it is so easily diagnosed with a simple semen analysis 2 to 3 days of abstinence. The guy comes in, collects the specimen. Why don't you wait 7 or 8 days? Well, it turns out you get a whole bunch of bad sperm, probably not the best he could do. Why don't you wait just 12 or 24 hours? Probably not enough time for him to build a new cohort. Well, what if he had like a severe cold or a virus or a bad fever? So wait a couple of months. It takes about 70 days for a guy to make a new sperm. So if he's been really sick, you can wait 2 months and you get a whole new cohort of sperm, and that's probably going to give you the best idea of what his average performance is. And if there is a, not that it's a performance, and if it turns out that there is a low count, it's important to repeat it. And if it turns out it's a very low count, it's important for him to be evaluated by a qualified urologist. So the male is really, really easy. The female is a little tougher, but you have to start with asking the same questions, the same basic steps and questions. Are there any environmental exposures? Has there been chemotherapy? Have there been any other major health issues? Because the body's pretty smart, just like with that ballerina. If the body has a chronic illness, if it's diabetes, if there's something else going on, if there's lupus, then there are many other organ systems that can be affected. So it's important to thoroughly evaluate the female and take a whole history and not just walk in and say, all right, it's either the eggs, the sperm, the uterus, or the tube. So we don't want to miss them. We can't assume that it isn't anything bigger than that. The fallopian tubes, we can usually get a rough assessment just by talking to somebody. Yeah, I was in college, I had chlamydia 3 times, and then twice gonorrhea afterwards in graduate school. Well, we're a little suspicious of a lot of things, including the possibility that she has tubal blockage, or monogamous, never had a pelvic infection, gone to the gynecologist every single year, no ruptured appendix. Well, her tubes are probably fine. So based on the clinical history, we can then figure out what the targeted test is to see if her fallopian tubes are open. The targeted test is straightforward. It's called a hysterosalpingogram. It's an X-ray. Woman goes to the radiologist, squirts dye through the cervix, and if it flows through the tubes are open. And if it doesn't flow through the tubes could be spasming, but in general, they're blocked. If the tubes are blocked, in the olden days, we used to do tubal surgery, and I did my training at Mount Sinai, and we did dozens of tubal surgeries. And it turns out that we don't do tubal surgery anymore because it didn't work that often, and in vitro fertilization is so much better. I mean, the majority of operating that we do these days in reproductive medicine is in a petri dish, putting the sperm into the eggs, and is no longer on a patient, putting in a scope or opening up and trying to open up a tube, because once the tubes are damaged, they're usually damaged forever. And we've done studies looking longitudinally at couples with tubal disease, and if you compare operating versus in vitro fertilization, whether they're 20, 30, 40, or 50 years old, without a doubt, in vitro is better than tubal surgery, so I'd say that tubal surgery is mostly now for those textbooks that are collecting dust on my shelves and no longer for driving how we practice medicine every single day. So we have the eggs that we now have to figure out. So if a woman is born with the eggs that she's going to have, and over time there's aging, how do we figure out whether somebody's got good eggs or not so good eggs? And how do we even figure out if she's ovulating or not? Well, you can tell if a woman's ovulating just by talking to her. I mean, not at that moment, but you can ask the question. You have, yeah, doc, I've got 28-day cycles. Around day 13 or 14, sometimes I feel this pain, sometimes the right side, sometimes the left side. About 9 days later, I get a little moody, a little bit bloated. I start to have some cramping. The period comes, and then it's rinse, repeat. The entire cycle happens over again. That woman is ovulating. You know that she's ovulating. There's no other way a woman can have a 28-day cycle. Biology is pretty straightforward. There's a regular access. There's a hypothalamic pulse generator that is sending out the signals to the pituitary, to the ovary in a timely fashion. A woman with 28-day cycles is ovulating. What about 26-day cycles? I'm sure she's ovulating. 30, definitely. Well, doc, sometimes it comes and it lasts for 2 weeks, and then it goes away for 3 months, and then it comes back again, and it's really heavy, and then it's gone for 3 months. That's a different story. That woman is either rarely or maybe even never ovulating. It doesn't mean she doesn't have eggs. It certainly means that the signals that are coming from her brain to her ovary are not coming in that regular pattern of FSH driving the follicle to grow, LH surging and causing the egg to be released, and either conception occurring and pregnancy ensuing, or period coming 2 weeks later and the cycle starting over again. So you've talked to the patient and you've helped them figure out whether she's ovulating or not. And then the next question is, well, when should she be having sex to optimize fertility? And people have studied this extensively, and people have filled out religiously in their journals, so there is a knowledge base of when to have sex to both not get pregnant if you don't want to, and of course to get pregnant if you want to. And it turns out that the sperm always should be there before the egg is released. So if a woman is ovulating on day 12, maybe she's got 26-day cycles, you always count backwards 14 days to figure out ovulation. She's ovulating on day 12, starting around day 8 or day 9, have sex every other day. What about every day? Probably okay. What about twice a day? Probably not enough time to give the male enough rest or enough time to build a new cohort to try again. So some of this is common sense that we do, but all of that I'm telling you has been actually studied in multiple journal articles. So I'm trying to synthesize the information, and there really is a science, even when we're talking about something as emotional and social as procreation. So sex is important before ovulation, and every other day is fine. Well, what about all those tests that you see in the grocery stores, the Walgreens, and call up somebody and run home? We have to have it at noon. It doesn't have to be timed that perfectly. It turns out that as long as sperm is there a day or so before the egg is released, that's probably fine for optimizing that month attempt at conception. What about sperm that gets there after the egg's released? Probably not as important. A couple of days later, sex is probably just for recreation and not procreation. So if a couple has now tried for a year, in fact, if the woman's over 35, the diagnosis of infertility is now given after 6 months and they're not getting pregnant, we do still worry, even with regular ovulatory cycles, about what about egg quality. So how could we figure out who's got good eggs and bad eggs? Well, part of it is the history. When did your mom go through menopause? Turns out when a woman comes in and says, well, my mom had a baby at 45, my grandmother at 50, my aunt at 70. I mean, that's a nice story, may or may not be true, probably not as predictive of her own biological behavior. When a woman comes in and says, yeah, my mom went through menopause at 30, my sister at 28, and all the women in my family have premature menopause, well, that's something that really is scary. And that's, again, where we're spending our time with genomics and personalized medicine, is trying to find out the genetic markers so we could figure out in advance who these women are. And I do foresee within the next 5 to 10 years, there will probably be tests available at the gynecologist's visit for a 21 or a 25-year-old woman, what's your reproductive destiny. And that's scary, too. I mean, I'm not sure everybody wants to know what their BRCA status is, especially if 25 and have the whole world in front. I don't think we're yet ready as a society to have all this information. If BRCA1 positive and I've got an X% chance of having breast cancer or ovarian cancer and I may need a mastectomy or have my ovaries taken out, as a society, it's possible that we'll head in that direction, but knowledge isn't always power, and knowledge can sometimes give more information than we're ready to have or even want to have at a certain point. So I think that there will be tests available in the future to predict a woman's reproductive future, but not everybody is going to want to avail themselves of that technology. So how do we know whether somebody's got good eggs or not? You take a history, and then you take a look with an ultrasound. And you can look at an ultrasound, and you can count how many follicles they have on each ovary. And a woman who has a high reproductive potential has a lot of follicles, these little black circles that pop up, 5, 10 on each ovary. And somebody with diminished ovarian reserve has fewer follicles, only 1 or 2 on each ovary. So you could just look at the ovary, and you can get a sense of where they are in their reproductive lifespan. And then the next test are blood tests. There are 2 biomarkers that are really informative when we try to figure out whether the eggs are good or not. One of them is FSH, and this has been around for decades. FSH stands for follicle-stimulating hormone, and it measures how hard the brain works at the beginning of the month to stimulate the ovaries. So if you've got good eggs, the brain doesn't have to work very hard, and you get a lower or normal FSH level. And if you have fewer eggs or older eggs, the brain pours that FSH, trying to beat those ovaries into working, and you get a higher and abnormal level. So by checking an FSH at the beginning of the cycle, we could figure out what a woman's reproductive potential is. The newer biomarker, and where personalized medicine starts to kick in, is a biomarker called AMH. It's anti-Müllerian hormone. And up until the last couple of years, it was really only interesting to embryologists and to studiers of comparative anatomy, because it helped determine whether a baby had a uterus or not. But it turns out that it's a hormone that's made by the ovaries, and a woman with a lot of eggs makes a lot of AMH, and a woman without a lot of eggs makes a low amount of AMH, and an AMH can be drawn any time of the month, not just at the beginning of the cycle, and it can be drawn when a woman's on the pill or when she's not on the pill. It's actually a hormone-independent secretion, and the levels are simple. If it's over 1, she's got good eggs. If the level's under 1, the eggs aren't as good. If the level's undetectable, we're going to have a hard time getting any eggs out. And she's going to have a hard time conceiving, both either naturally or with assistance. So we know the sperm is good because we've done a semen analysis after we took a history. We know the eggs are good because we took a history. We did an ultrasound. We did the blood test. We know if the tubes are open because we've done that hysterosalpingogram. And then we look at the uterus, and we figure out if the uterus is normal by doing an ultrasound. Fibroids, polyps, unusual shapes, scar tissue. how thick a lining can get. So there are some structural ways we could look at the uterus. But we put the whole story together, and we could pretty much figure out who's going to get pregnant and who isn't going to get pregnant. The treatment of couples with infertility used to be fertility pills, inseminations, fertility shots. It's streamlined these days. Most patients that come in may be low tech for a month or two, but ultimately in vitro fertilization is becoming almost a first-line treatment for couples that come in having difficulties conceiving. And it is incredible how IVF has changed within the last 24 months. I've been at Sinai now for 22 years. The changes in the last 2 years have actually been more dramatic than in the 2 decades before. So what we used to do is give shots, take out the eggs, fertilize them, and throw in a bunch of embryos and hope that one, well, we were more elegant than that maybe, but we would very gently transfer the very best embryos, 15 millimeters from the top of the uterus, lay them down ever so gently and hope that a pregnancy ensued. And we looked at getting pregnant as a good outcome. We looked at twins as a good outcome. We even looked at triplets. Well, at least, amortize the babies. We really didn't have any full understanding of the public health problems that we were causing by the higher order multiple gestations in our society. In fact, pop culture got it right when they started mocking the reproductive medicine world, that it really was almost a baby race. And back in the 90s, when we had the quintuplets that were born in Texas, and then there was another one in California, and then of course the octuplets and Octomom, and I think that we began to realize that it wasn't about how many babies somebody can have, and that even when there were healthy babies being born, by and large, babies that are born prematurely, moms that were pregnant with multiples, were not having as healthy an experience. So these days, it is one embryo and one baby. We have actually, when we do in vitro fertilization, 90% of the embryo transfers that we did in 2004 were at least 2, and half were at least 3 embryos. This year, 70% are 1 embryo and 30% are 2 embryos. Next year, we're looking to get close to 100% single embryo transfers. Now, twins aren't necessarily bad. You can ask our 18-year-olds. They're fantastic. Our little occupational hazards. But it turns out that twins are often born prematurely, often can have developmental issues. The moms pregnant with twins end up on bed rest frequently. The incidence of gestational diabetes, of preeclampsia, it's not benign for mom, and it's not benign for the babies to be born prematurely. So our field is coming of age. There are 175,000 cycles of IVF in the United States, and up until recently, the incidence of twins was close to 40%, and we just had a conference in Baltimore. We're all getting together. We're trying to eliminate triplets from the vocabulary, and we're trying to have all singleton babies. And it's so interesting. We ran the data from our program. Babies that were born in 2014 from IVF in our program at the Mount Sinai IVF program are 1/2 pound bigger than the babies born in our program 5 years ago, which is astounding. I mean, could you imagine actually finding some magical droplet that you could put in the culture media or the dish or to make babies born 1/2 pound bigger, to have pregnancies last 2 weeks longer? What did we do? We started to pick out 1 embryo. So how do we pick out the best embryo? And this is the really cool part of it. We can actually take an egg, fertilize the egg, grow an embryo, it grows to about 100 cells. We use a laser and we chop off, dice off, fry off, take off about 5 to 9 cells off the outside. And then we take that cellular material and we amplify it, and we get all the DNA that embryo has. So from that DNA, we could figure out whether the fetus is going to be normal, how many chromosomes it's going to have. It's going to be Down syndrome, trisomy 18, monosomies, complex chaotic errors in genetic copy numbers. So we can figure out if it's chromosomally normal. And also, as I talked about the 6,000 single gene mutations, if we know that mom and dad are at risk of having an unhealthy baby, we can actually take the DNA, amplify it, and figure out whether that embryo is not only chromosomally normal, but isn't going to have cystic fibrosis or is not going to have Tay-Sachs syndrome. So these days what we're doing is for patients that are trying to get pregnant, we're taking their embryo, we're amplifying and analyzing the DNA, and we're finding the normal healthy embryo. For couples that are at risk of having a baby with a genetic disease, we're figuring out which of the embryos that don't express the disease or at least carry the disease. We're looking for the healthy embryos to put back in, and it's been a game changer. The other thing that we're doing, which is very, very interesting, I mean, this is the future of reproductive medicine, is you can't get all that information very easily in a fresh cycle. So in other words, we take out the embryo, we biopsy it, take out the egg, fertilize it, biopsy it, get the information immediately and put it back in. It's not that simple, so we're freezing, we're vitrifying these embryos, and then a couple of weeks later, at the perfect time of the cycle, we're putting the embryo back in. This way we could focus on the retrieval cycle, on getting the best seed, on getting the best egg, and in the frozen transfer cycle, get the best soil, getting the perfect window of implantation so we could take the embryo and elegantly put it in. And that's what's changed the game. We're screening embryos, we're picking out the best one, we're putting it into the perfect environment, and now whether someone's 20, 30, 40, or even if they have a healthy embryo, or especially if it's a donor embryo, up until 50, we can get implantation rates of close to 70%. So we're not having failed cycles, and most importantly, we're hardly having miscarriages anymore because we're not putting back unscreened embryos. So when we talk about this journey that we've been asked to talk about today, when we talk about the story of before a baby is born, what mom can do to optimize the health and optimize the gene expression, through puberty and as a society, making sure that we're responsible for what we put into the environment, and handling the obesity epidemic, and improving nutrition, all the way through markers to help figure out who is at risk for having reproductive issues, both for medical reasons and reproductive reasons, and taking it through the streamlined diagnosis and treatment of infertility. I think we're making dramatic strides, and this is where we should be having these Women's Health Days. I mean, reproductive health is a couple's issue, but it is very, very much a women's issue, and the reproductive journey starts more early than anybody could ever imagine. So we're helping women up until 50 routinely get pregnant. Over 45, it's hard to have a normal egg, so we're often using eggs donated by younger women, and now there are egg banks, so it's not that hard to go online, find a suitable matched donor, have the eggs shipped, fertilize them, and transfer the embryos. The Society of Reproductive Medicine now says up until 55 years of age, ethically and socially, because women are living longer and are healthier, and as long as there's appropriate maternal fetal clearance by a specialist. So we're helping women later on in life have babies. But the next stage, of course, is what about if they're menopausal? What is the menopause? How has that menopausal shift occurred in our society? So the average age of menopause is about 51 years of age. It hasn't changed that much in the last century. What's changed is the awareness of menopause. So people are talking about it more. The menopausal transition starts on average at the age of 46 or so. It's about 5 years of first periods often get shorter, then they start to lengthen. Hot flashes are a major problem. And the story about whether to use hormone replacement therapy is one that, I mean, I've gotten up on the podium for 2 decades, and I've given talks that every woman should have hormones. And the next year, I read the studies, no one should have hormones. And the next year, everyone. I mean, I have flip-flopped more than some of the people in these presidential debates over the last weeks. And I don't know the answer, but I could tell you that over the last 30 days, a number of studies have come out. And it turns out that hormones are now good, as long as they're started early. In other words, 50-year-old comes in with hot flashes, with menopausal symptoms. If you start hormone treatment, they will actually feel better, and their life expectancy will definitely not be shortened. If you wait 10 years, then they have an increased risk of strokes, of blood clots, and of major health problems. So the story that we're hearing right now is it is possible that estrogen and progesterone therapy over time may have a slight increase in breast cancer. And it may be as high as 2% more for women that are on hormones. But most of that seems to be related to progesterone and not estrogen. And there are a lot of ways you can give hormone replacement therapy without the old-fashioned way of giving progesterone. So I don't take care of as many menopausal patients. This is not exactly my field of expertise, so I can't say that 100 women have come in the last week and this is how we treat them. But I would say that the standard of care right now for a 50-year-old who's suffering from hot flashes is to treat her with estrogen, now transdermal through the patch rather than oral, because the oral was actually causing a lot of the blood clots and the heart disease. The patch actually doesn't go, the estrogen doesn't go through the liver, so you don't have that same revving up of all the proteins, thickening of the blood that is causing some of the clots. So the standard of care these days is usually giving some estrogen, staying on it, and then possibly tapering it down or possibly cold turkey. And about the literature is split consistently on whether symptoms are better, just ripping off the Band-Aid, or whether it is very gently over time, just peeling it off. In other words, stopping estrogen replacement therapy gradually or just stopping it abruptly. But the story on menopause is we can take care of symptoms with medications such as Paxil, which is a serotonin reuptake inhibitor. We can take care of it with some calcium channel blockers. The symptoms of hot flashes are significant and disruptive. We can take care of some of the mood swings. Osteoporosis, I know I'm getting the sign that we're going to go to question and answer in a few minutes, but calcium, vitamin D, weight-bearing exercise are essential. It is far easier to keep bone mass than regain it when lost, so having adequate estrogen throughout a woman's lifetime is important, and making sure a little bit of sunlight, a little bit of calcium. I know the dermatologists aren't going to like my saying that, but we can actually optimize bone density while we have good reproductive function, and therefore, even though there's inevitable bone loss in women 60s and 70s, if we start with a higher level, then we're going to lower the risk of ultimately having fractures later on. So we could treat the symptoms of vaginal dryness, of cognition, of hot flashes with medications, but it's important to have a good doctor that's taking care of you, and we need to address the issue of heart disease in women. Heart disease in women kills more women. Heart disease kills more women than breast cancer, even though we know more people with breast cancer because it's a prolonged disease and we see them go through chemotherapy and hair loss and we see people suffer. Heart disease kills instantly. So the next chapter in women's medicine is going to be early awareness of heart disease, appropriate screening programs, just like we've almost eliminated deaths from breast cancer in the reproductive generation with early screening and with awareness. It's time to put that same type of energy into hearts. So personalized and genomic medicine is here to stay. We're all going to learn more about us and our next generation even more about them than we could have ever meant. Not all the information is good or helpful. Some of it is going to be a little bit scary, so I think that putting in the framework to learn about what we're being tested for and test for actionable things. In other words, probably as a society, we're going to know when something is wrong if we have a way to treat it and cure it and deal with it and handle it. There's another 1,000 genes we didn't even talk about that have some type of a cancer predisposition, that are variants in the genetic code of, they call VUS, variants of undetermined significance. I think we have to be careful before telling every one of us that we're a mutant. I think that the future is really, we're all a little bit damaged in some way or another. But I think that the future is actually going to be using this knowledge to prevent disease and to promote health. Well, thank you for letting me just take you on this journey through reproductive medicine. And I would be happy to take some questions about any of the 500 eggs. Yes?
What about autism? Because it seems like there's like a test for every single other thing, but now it seems to me like all of a sudden there's so much autism. So what is happening?
It's a great question. So autistic spectrum disorders are definitely more prominent in society. Awareness is more prominent in society these days. It's not a single mutation or a single gene that causes autism. It probably is more of gene expression. So it's not somebody's DNA, so it's not that easy to test for, but it is whether that DNA gets transcribed in a certain way. Inside of the laboratory these days, we're actually studying gene expression. So I would say within the next couple of years, we may very well be able to answer that type of a question. So it turns out that there's something really simple. It's a CH3, it's a methyl group that sits there right before that gene starts. And if you've got a methyl group on it, the gene doesn't get expressed. And if you take it off, then the gene gets expressed. And a lot of cancers are probably caused by that methylation process. Autistic spectrum diseases are probably caused by genes getting turned on and off. And there are they're called GWAS, genome-wide associations. People are analyzing all the genes and looking at diseases in rheumatoid arthritis and cirrhosis and many different diseases, and they're finding a lot of genes of interest with Alzheimer's and with autism, but there isn't a specific test yet. So I would say that as a society, there's definitely more awareness. There's definitely more labeling. We used to think of these kids as being difficult or challenging or special or just not normal, and now we do have definitions. So I think may or may not be more prevalent in society. The studies seem to show that there is an increase, and we don't exactly know why, but I think that there will be a genetic and a transcription of the genes basis that will be elucidated pretty soon. Yes?
Can you talk a little bit about some of the ethical issues that you might face in fertility treatments? For example, are there any psychosocial situations or medical situations or domestic situations that you might see that would impact your willingness to proceed?
It's a great question. So we talked a lot about the science and a little bit about the emotions today, but there is very much an ethical component. And just because we can do something, it doesn't always mean that we should do something. And that 60-year-old that comes in and just wants to have a baby so that her life is complete, a 50-year-old with a 0% chance of getting pregnant from in vitro fertilization, she wants to give it that one shot because she knows somebody who she thinks got pregnant using her own eggs. The couple that's getting divorced and but wants to have one baby to try to bring them together, and you sit across the table and you have to go back to the basic ethical tenets of autonomy, which is what the patient wants, beneficence, your desire to do good as a physician, and non-maleficence, the overriding principle to not do harm. And we face it every single day. I mean, we have a psychologist, Georgia Witkin, on our staff, and there's like a line outside of the door to her office some days because some of these questions are not that simple. Couples that, one couple, the husband, it was an arranged marriage, and the couple wanted a lighter-skinned donor because it was an arranged marriage, and he wasn't happy that his wife had dark skin, and so he wanted donor eggs so that he can have a light-skinned baby so that they would have a higher social status. And it made us cringe, and it made us queasy, and there's no textbook that tells you how to handle these situations. And then the list goes on and on. We have had couples that have both husband and wife carry a gene for hearing loss, a mutation for hearing loss, and they have a baby who's deaf. The next baby, there's a decision. Do you screen so that the next baby can hear? Do you play roulette knowing that 1 in 4 babies are going to be deaf, even though we have the technology to easily prevent that? Do we screen so that we have another baby with hearing loss so that what's normal in that family is the next child, so that both kids are going to have the same situation, because hearing loss is not seen as a deficit in that family. It's actually celebrated as the way that they communicate with sign language, and it would make the first baby feel badly that they were selected against in the next. So, I mean, we could, at our dinner table, believe it, almost every day there are conversations about these type of ethical issues, and they're troubling. And I mean, the situations, you have to go back to the basic principles of what does New York State Department of Health say? Sometimes the CDC or the FDA weighs in on decisions, sometimes the Society of Reproductive Medicine, and sometimes it is just that front page of the Post test, which is if you're going to end up on the front page of the Post, it's probably not something you should be doing. You know, sisters, eggs, brothers, sperm, grandfathers, uterus. Like, I mean, there are crazy combinations that people come up with over time, and you just want to. You have some responsibility, and we're careful to not say that the embryo has status, because there are 11 states that would be more than happy to call us mass murderers as reproductive endocrinologists because they want embryos to be people. So I don't want to say that the embryo has rights, but I would say that we have a social responsibility to think about not just taking a 65-year-old woman and giving her an embryo. I care about what happens to her, and I certainly care about this kid at graduation, but it is part of what we struggle with every single day. Yes? Great question. So infertility and postpartum depression is the question, whether there's a correlation. And postpartum depression, currently estimates somewhere between 15 and 23% of women who deliver have some symptoms of postpartum depression. And my guess is it's probably closer to 100%, but it's just the diagnosis that we're not really fully asking the right questions about. Sorry, let me just answer the question about infertility. Anytime there is difficulty conceiving or some type of a psychosocial struggle with getting pregnant or marital difficulties beforehand, these are all risk factors for later on having postpartum depression. A woman who is on bed rest, a woman who has had complications of pregnancy, had intrauterine fetal surgery. So we're learning more and more about risk factors for postpartum depression, and infertility is clearly a driver of stress in a marriage, a driver of divorce, and a driver of postpartum depression. And we probably need to do a better job of creating a safety net, because for us, pregnancy shouldn't end when the woman is 6 weeks pregnant and has a heartbeat, but we should probably be long aware. Hopefully with singletons instead of twins, there will be a little bit more sleep postpartum, and that's going to be one of the coping strategies that maybe somebody can have as they go through a difficult time afterwards, as the hormones change after pregnancy. Yes? Can we choose the sex of an embryo? Easy, really easy. We take out the eggs, fertilize them, take the embryo, biopsy it. If it's got we start amplifying the points. Y chromosomes are very different than X chromosomes. All the points are just different. The genes are different. There are 21 novel genes on a Y chromosome. You could look for any of them, and you can very easily tell a boy from a girl embryo. Spinning the sperm won't tell you, give you a boy or a girl. There are lots of old wives' tales that talk about debunking myths. Since the dawn of civilization, people have been trying to predict boys versus girls, because the X chromosome has 3% more DNA than the Y chromosome, so the X is a little bit heavier, so in theory the Y should swim a little bit faster, but it turns out that that difference is not meaningful. So the timing to ovulation doesn't really matter, the number of days, the position, the phase of the moon, none of that really matters. So the answer is yes, it's easy, but no, don't try this at home. Yeah. Sorry, yes? Mm-hmm. Yes. Yes.
Now, because 5 years ago, it wasn't the same case. It was more, wasn't the embryo getting a little bit, not ruined, but it was more of a risk?
Yes. So the question is, how are we safely culturing these embryos for 5, 6, 7 days in a dish, freezing them, thawing them, and seeing that it's better, when the prevailing dogma a decade ago was we got to take out the embryo, put it back in as soon as possible, because the uterus has to be better than our incubators. It turns out that we've made up ground and passed the uterus with our incubators. So changing the gas concentration, changing the culture media, improving our QA conditions, we can culture out embryos. They don't die, they don't arrest in our dish if they're normal in general. In fact, our fellow, that's what one of our thesis is going to be, taking a look at why some embryos do stop growing. But it turns out that our incubators and our culture media is probably just as good, if not better, than the uterus in helping an embryo, because we could see that. If 70% implantation rate versus the natural conception rate of 15%, so we're doing something right inside the dish. Maybe not everything right, but I think that we are not hurting the embryos. All right, I'm getting the hook. Well, I'm happy to stand up here afterwards. Thank you all so very much. Hope you all enjoy lunch.